All right. This is an update from the surgery department, Mary Washington Hospital, to all members of the surgery department. Thanks for listening. It's August 15th, 2018. I try to do this every couple of months. I wanted to remind people about the OR committee function. A lot of people don't come to the surgery department meetings or the operating room committee anymore, but the OR committee actively tries to help meet your needs in the surgery department. We try to match staffing needs, nursing, technician, first assists with the demand. If you feel that there is an unmet need, please let Lisa Matheson or let me know, and we'll try to do the best to meet your needs in the OR. We certainly survey block time metrics, and we grant block time. We adjust block time depending on your needs and your past utilization. We monitor it by in 3-month blocks, so make sure you use your block time, or if you don't have cases, make sure you release your block time a week ahead of time. Otherwise, it will count against you in the statistics that we gather. So block time maintenance and oversight is an important function of the OR committee. We also review a lot of patient satisfaction scores. We're working hard to make your patients have a good experience. If you have feedback for the OR committee about poor patient experiences in any department of the hospital, in the surgical services, then please let us know. We're also helping Lynn to redesign the pre-admission testing process. That's a big initiative. We hope that you'll take advantage of it. It's rolling out next month in the 1st of September. They've expanded the staff in pre-admission testing. They've hired new nurse practitioners. They're trying to adopt a one-call model similar to what you would see at academic and larger institutions, where when you book a case 2-3 weeks out for a patient with medical comorbidities, maybe an ASA4 or an ASA3 patient, one phone call to the PAT, and they'll take the ball from there and contact the patient. They'll do the history and physical, they'll do all the lab testing, they'll get the cardiology consults, they'll take all those worries off of your staff. This is a model that's been in effect for orthopedics and for other product lines for the past several years. And we are trying to expand it to general surgery, neurosurgery, urology, anyone who does major cases on elderly patients with medical comorbidities. So please use the new pre-admission testing process, the one-call model. We're also, in the OR committee, we're trying to drive down turnover time. We're actually making progress. We're down to less than 30 minutes now, which is wheels out to wheels in. That's the measure of appropriate turnover time, and we will keep working on that. I wanted to remind surgeons, please try to arrive on time for your starts, for your first case starts in the morning. If you have a 7:30 start on the board, you have to be there and see the patient and check in with the front desk by 7:20 at the very latest. 7:15 would be better. Otherwise, you will be marked as surgeon late, and those statistics do come to the OR committee for review, and that might influence your access to first case starts in the future if you are habitually late. So please try to be on time. Use the new pre-admission testing process that I just described, that Lynn is rolling out in the next few weeks. And one final reminder, again, to please release your block time if you are going out of town, or if you have no cases. Release your block and it won't count against you. You do have to release it a full week ahead for elective cases. I wanted to remind people about what's called the CQV process. The CQV committee is the one that approves new devices for the operating room, new vessel sealing devices, hemostatic devices, laparoscopic tools, things of that nature. Remember that you can't just request it and expect the hospital to buy it. The process in place for many years has been that you fill out a form, you request it, a brief analysis is done by the CQV committee, and after that it is presented to your entire division. Your peers must then vote yay or nay on the hospital's purchasing or making a change in equipment. So you have to follow that process. It's worked well for many years, and please remember that process if you have new devices that you wish to trial or you wish to substitute in the operating room. The final approval is rendered by the CQV committee based on the division's request and your individual request for a new product. I wanted to remind everyone on HRO training, high reliability training, that's still ongoing, and most surgeons have done their HRO training, but some have not. And I want to remind you that if you missed the HRO training sessions 3 to 4 months ago, you must be checked off on your HRO training before you will be reappointed. Reappointments occur every 2 years, and you must have that checked off. There is an online version of the training now, which the medical support services can point you in the right direction if you need to have that training. Otherwise, you will lose your appointment at the hospital on the 2-year cycle. I wanted to talk about robot block time. The robotics program is expanding and growing. We have new surgeons utilizing robotic techniques, and I want to remind people that there is plenty of open robotic time. There is a lot of delegated block robotic time as well, and as the needs for robotic surgeries expands, we will also expand the availability of the robot perhaps later in the day or into the early evening as necessary in the future. But please, if you anticipate hiring a partner with robotic skills, talk to the OR committee and we can let you know what days of the week are available for open time and for block time with the robot. The robot has to be used in room 14, as you all know. Wanted to talk about the surgical advanced providers, advanced practice providers. This is Stephanie and Cara Lee. Stephanie is a nurse practitioner. Cara Lee is a physician assistant. Cara Lee is assisting mostly bariatrics and general surgery and some urology. Stephanie is assisting mostly orthopedics. They are both very, very busy, but they love helping you to take care of your patients on the floor. Please use them properly and efficiently. Give them a call, give them a text. If you have any reproducibility in your schedule, when you'll be rounding, when you would like for their help in taking care of your patients, the more lead time you can provide them, the better, because they are extremely busy at this time. Finally, I just wanted to remind surgeons about proper hand washing policy. You have to follow the policy. You have to wash your hands before the case, obviously, before you don your gloves, but also when you finish the case, you have to wash your hands before you go about your business. The surgical attire policy is being watched, and that's important every time there's reaccreditation of the hospital. If you have soiled shoe covers, you have to discard them after the case. If you have a personalized hat, you need to keep it covered with a bonnet. If you walk into the hospital with scrubs that you've worn in from home, you have to change those scrubs and use hospital laundered scrubs before you scrub on the case. So there is a policy governing all of those attire issues. Finally, I want to talk about the surgical consent form. That was changed a few weeks ago. There is a new paragraph added for DNR patients. If the form that you are using has that paragraph, and if the patient has a DNR policy, you have to have a brief discussion with the patient and check off the appropriate box about your conversation with the patient. Do they want the DNR suspended during their time in the operating room or in PACU, or do they not want it suspended? And that is language that has been adopted nationwide and is language that is now an important part of our consent form. So that's all I have for you today in mid-August, and thank you very much for coming to the hospital and using our operating room services.